You can pause the recording. Right.
There you go. Hello, I'm Dr. Ismail Beghi, and I'm joined here with Dr. Aman Rajpal and Leili Rahimi. We would like to discuss COVID-19 in patients with type 2 diabetes. We would like to investigate what are the factors leading to the high mortality and morbidity in patients with diabetes. So the main scientific question here is what is so specific about diabetes that increases the susceptibility to acquire perhaps COVID-19, and once you acquire it, why the patients would have such a severe disease. Now, as you recall, the virus is named SARS-CoV-2, and the disease itself is named COVID-19. In this schematic here, we're trying to explain what are the perturbations in type 2 diabetes. As you know, type 2 diabetes is more than just having increased insulin resistance and having hyperglycemia because the beta cells don't secrete enough insulin. It is a condition where it's highly correlated with obesity. The bulk of the patients have hypertension. Many have cardiovascular disease. More than half have dyslipidemia. And certainly higher age contributes to developing diabetes. So it is a mixture and an amalgamation of all these different factors. Then also patients with hyperglycemia, the whole condition of the obesity and hyperglycemia causes a chronic state of inflammation, which gets much worse with the entry of the virus. The virus enters the body through this particular protein, which we'll discuss a little bit more later, called ACE2, seems to be the major port of entry. And that entry causes the inflammation to get worse. There's a hyperimmune response, which also is aggravated by SARS virus itself. And then in the net, you get a very severe disease. So we would like to explain these components, how they feed into a final common pathway. So I will spend a couple of minutes of introduction. Then Dr. Leili Rahimi, who's sitting here on my right, will talk about obesity, hypertension, cardiovascular disease, dyslipidemia, and age, and how they contribute to severity. Dr. Rajpal will talk about type 2 diabetes itself, the role of hyperglycemia, ACE2, and inflammation. And at the end, I will give some concluding remarks. Now, just in general, this is a paper. There's many that are like this. This is on 5,700 patients hospitalized in New York. And what you can see is that the median age is around 63 with a very wide range of years of age. Male to female, there's a little bit of preponderance of males. And it's not exactly clear why this is. It may have to do with the sex hormones, but it's not exactly clear. The bulk of the patients with COVID have hypertension, a large number are obese, and as a matter of fact, this may be one of the main reasons of severity, and a large number have diabetes. And these percentages vary depending on the study and the presentation. Now, that particular protein ACE2 is expressed in lung alveolar cells and endothelial cells throughout the body, expressed in the heart, kidneys, importantly in beta cells and many other cells, including the brain. And ACE2 expression is augmented in diabetes by hyperglycemia and ACE and ARB medications. And recently it's been shown that inflammatory markers themselves can stimulate ACE2 expression. So just as a short review, as you recall, angiotensinogen is made by the liver, and in the bloodstream by renin, it is converted to angiotensin 1, which is 10 amino acids long, and by the action of ACE, it is converted to angiotensin 2, which is 8 amino acids. Angiotensin 2 interacts with its own receptors and increases aldosterone secretion, but also it has other effects that are not necessarily positive. There's inflammatory mediators are activated. it increases vascular permeability, and it also causes inflammation, which makes the disease severe. Now, we've shown and we've discussed, and we'll discuss more, that the virus enters the body through ACE2 receptor, that's a glycoprotein on the cells. ACE2 is an enzymatic activity that converts angiotensin 2 to angiotensin 1,7 by clipping off one amino acid. This particular peptide has effects that are somewhat opposite to angiotensin 2. In other words, they increase blood flow and cause vasodilatation, decrease inflammation, decrease insulin resistance. So in an important way, the balance between these two proteins and peptides seems to be quite important in how the patient is going to respond to this infection. So here, again, we have the original schema, and Dr. Rahimi is going to speak to some of the factors that we have mentioned already.
Thank you, Dr. Begi, for the introduction. Hello, everyone. I'm Dr. Rahimi. I'll be talking about how these factors that, as you can see, they're all interrelated to each other, can result in increased inflammation and can result in increased severity of COVID-19. The factors that I'll be talking about are obesity, hypertension, cardiovascular disease, dyslipidemia, and old age. So starting with obesity, which is very common among patients with type 2 diabetes, has shown that it played a significant role in increased hospitalization and severity of this disease. Based on the study that was done in New York City on 4,100 patients who had COVID-19, it showed that severe obesity was the second strongest independent predictor for hospitalization after old age. In another study that was done in Shenzhen, China, on 383 patients with COVID-19, showed that obesity was associated with 2.4-fold higher odds for developing severe disease. So what are the mechanisms that can predispose obese patients to more severe disease? Well, first of all, obesity is highly related to insulin resistance, which can contribute to increased inflammation in the body. Also, there are other factors that can cause increased severity of this disease, such as low lung volume and impaired gas exchange that we can see in patients with obesity that can lead to increased risk of respiratory failure and increased severity of the disease. Obesity is also associated with increased hypertension. It can cause it by various pathways, including stimulating the sympathetic nervous system, renin-angiotensin-aldosterone system, and by obesity-induced chronic kidney disease. Hypertension, in turn, can cause insulin resistance and increase the inflammatory state in the body. And also, obesity can be considered as a chronic inflammatory state of the body in which we have elevated levels of inflammatory cytokines, elevated levels of leptin, which is considered as a pro-inflammatory factor, and we have low levels of adiponectin, which is also considered as an anti-inflammatory factor. So all these factors can contribute to increased inflammatory state in the body and can lead to increased severity of COVID-19. Then we have hypertension as a very common comorbidity associated with patients who have type 2 diabetes. Based on a pooled analysis that was done by Leili et al., showed that hypertension was associated with 2.5-fold increased risk for severity and also for mortality in patients who had COVID-19. So then the question would be, how can this happen and why hypertension is associated with increased risk of severity and mortality in patients who have COVID-19? Hypertension can lead to insulin resistance through different mechanisms, by stimulating sympathetic nervous system, by increasing the inflammation and oxidative stress. It is also suggested that hypertension can impair and alter glucose and insulin uptake into skeletal muscle, leading to insulin resistance, causing increased inflammation in the body. This is also mutual, meaning that insulin resistance can also cause hypertension by increasing sodium reabsorption in the body, by stimulating vascular smooth muscle proliferation, and also by stimulating sympathetic nervous system and increasing the inflammation. Also, in some types of hypertension, we have elevated angiotensin II, and I just wanted to point out some of the characteristics of angiotensin II, which can increase the ACE2 expression, which is a pathway for the virus to enter the human cell. It can increase the aldosterone, inflammatory mediators, and it can cause vascular permeability, especially in the lungs. That can result in insulin resistance, inflammation, and more severe disease. And as we all know, hypertension can cause cardiovascular disease, leading to insulin resistance. Then we have cardiovascular disease, which is another common comorbidity in patients who have the type 2 diabetes. Based on the meta-analysis that was done on 1,500 patients, showed that pre-existing cardiovascular disease was associated with a threefold greater risk for developing severe COVID-19 or requiring ICU admissions. In patients who have cardiovascular disease with its associated risk factors such as hypertension, dyslipidemia, old age, and type 2 diabetes, they have increased insulin resistance in the body and increased inflammatory state in the body. So when we have the SARS-CoV-2 to enter the body, this inflammation increases. We have cytokine surge, which in turn can lead to plaque instability, increased demand for higher cardiac function, and increased sympathetic activity in the body. This can lead to severe cardiovascular complications, such as acute myocardial infarction, myocarditis. Some patients can present with heart failure or arrhythmia. It can cause cardiac arrest, and it can cause thromboembolic events, which is a very significant complication in patients with COVID-19. And I just wanted to point out that some medications that we have been giving to these patients also can cause some cardiovascular complications, such as hydroxychloroquine that can cause direct myocardial toxicity or prolonged QTc. Remdesivir can cause hypotension or arrhythmia, and azithromycin can cause also prolonged QTc, AV block, or torsade. And then we have dyslipidemia, which is common in 30 to 60% of patients who have type 2 diabetes, and is also characterized by elevated triglycerides, by elevated LDL, and low level of HDL. As you can see in this slide, elevated free fatty acids can accumulate in the liver as triacylglycerol. When they get released into the blood, their VLDLs rich in triglycerides. They can deposit in peripheral tissue and cause insulin resistance. They can also lose the triglyceride part and turn into LDL in the blood, which is small and dense and is more atherogenic, that can cause cardiovascular disease. Elevated free fatty acids also can directly stimulate cytokine secretion by stimulating toll-like receptor 4 on immune cells. And they can also cause cardiovascular disease, which in turn leads to insulin resistance and more inflammatory state in the body. And then old age, which has shown previously that it contributes to increased mortality in SARS and MERS. And now we are seeing similar results in patients with COVID-19. Based on a study that was done on 191 patients, it showed that the mean age of patients who did not survive from COVID-19 was 69 years old, as compared to the survivors whom mean age was 52 years old. And another study on 138 patients showed that the mean age of patients who ended up to ICU was 66 years old, compared to the patients who did not need ICU care, which the age was 51 years old. So with increased age, we might have associated dyslipidemia, hypertension, cardiovascular disease, diabetes, and insulin resistance, which can increase the inflammatory state in the body. Also at old age, we have T cell and B cell dysfunction leading to increased cytokine secretion in the body. and with increased age, we have elevated numbers of senescent lung cells. These are the cells in the lung that are called, that they have senescent associated secretory phenotype, which means that they have enhanced protein synthesis characteristics, and they can produce large amounts of inflammatory cytokines and also immunomodulators, such as interleukin-6. This characteristic makes them a very ideal host for viruses to replicate in. And it is suggested that the SARS-CoV-2 prefers these cells, and they target these cells to enter and replicate in it and cause more severe lung inflammation and fibrosis, leading to more severe disease.
Dr. Rajpal, before you say, can I say at least one sentence about age, just to amplify what Dr. Rahimi was saying? In a very recent study, I noticed that over 10,000 patients with COVID-19 and diabetes that had died. The age distribution is quite wide, but compared to an age of 45 or 48, if you risk factor of death is 1, by the time you get to age 80, the risk factor is 30-fold. So there's a huge steep curve of age here. And of course, there's more frailty, but it is a very important parameter. So in many studies, age has to be canceled out and accounted for before you can actually make any kind of a statistical argument.
Well,
Dr. Rajpal?
thank you. Hi everyone. I am Dr. Rajpal, one of the endocrinologists here at Case Western Reserve University in Cleveland, Ohio. Thank you, Dr. Ismail Beghi, for the great introduction to the topic, and thank you, Dr. Rahimi, to talk about some of these factors that, as mentioned before, are present in patients with type 2 diabetes. So here I'm gonna try to talk about type 2 diabetes itself and some of the other factors such as insulin resistance and hyperglycemia, and how these factors possibly lead to inflammation, and then what is the association between increased inflammation and severity of COVID-19. So I'm going to start with type 2 diabetes first. So what evidence do we have? So if we look at this table, which was from a study by Wang et al., where they retrospectively looked at 138 patients who were admitted with COVID-19, and they compared patients who were in the ICU versus not in the ICU. And as one would expect, patients who were in the ICU had more likely had all kinds of comorbidities. But if we specifically look at diabetes itself, if you had diabetes, it was 4 times more likely to be in the ICU versus not in the ICU. So again, suggesting patients with diabetes possibly were having severe disease. And similarly, if we look at the graph on the right side, which is from another study by Guo et al., which was also a retrospective analysis, and here they used a score on the CT scan as a marker of severity of pathological changes. And higher the score means severe disease. And as it shows here, that patients with diabetes had significantly higher score as compared to patients without diabetes, again showing that patients with diabetes possibly were having severe COVID-19 illness. Moving on to this another study by Board et al. Here, where they also looked at patients who were admitted with COVID-19, and when they compared patients who had either a known history of diabetes or had uncontrolled hyperglycemia or stress hyperglycemia during the hospitalization. And here's the stress hyperglycemia or uncontrolled hyperglycemia was defined by having at least 2 blood glucose levels more than 180 milligram per deciliter within a 24-hour period. And patients with either diabetes or uncontrolled hyperglycemia had a mortality of around 29%, as compared to patients without these 2 factors, the mortality was only 6%. So again, suggesting significantly higher mortality in this group. Similarly, there's another group where they did a retrospective analysis of patients admitted with COVID-19, and they found that patients who had type 2 diabetes and were admitted with COVID-19 had a mortality of around 8%, as compared to patients without diabetes, where the mortality was close to 3%. So again, suggesting severe illness in patients with type 2 diabetes. So talking about possible mechanism underlying, so we know that most patients with type 2 diabetes have underlying insulin resistance, and there is a known hypothesis or thought that insulin resistance causes inflammation, especially in adipose tissue. So if you look at this model of adipocyte, so usually the insulin molecule enters through the insulin receptor and upregulates this protein, the mTORC2 protein. And this inhibits the insulin resistance and initiates or lets the insulin to work well. But in patients with type 2 diabetes or obesity, basically there is downregulation of this mTORC2 molecule, which in turn leads to insulin resistance. And insulin resistance leads to production of this MCP1 protein, which is the monocyte chemotactic protein 1. And also in patients with type 2 diabetes and obesity, they have this N-type JNK protein, which is another protein, which also leads to the production of MCP1. This MCP1 leads to accumulation of pro-inflammatory macrophages, which leads to production of TNF-alpha and other cytokines, which basically leads to inflammation. So this chronic state of inflammation ongoing in these patients with type 2 diabetes and obesity or due to underlying insulin resistance possibly gets enhanced with an infection such as COVID-19, which can lead to severe disease in COVID-19 in patients with insulin resistance. So moving on to talk about hyperglycemia itself. So again, going back to the study by Bode et al., which was a retrospective analysis of 1,100 patients admitted with COVID-19 in 88 US hospitals. Out of this 1,100 patients, 451 patients had either a known history of diabetes or had uncontrolled hyperglycemia, which as mentioned before was defined by two blood glucoses of more than 180 milligram per deciliter within a 24-hour period. Out of this 451 patients, 184 had some kind of an outcome. Either they had mortality or they were discharged. So when they looked at these 184 patients closely in this table, they divided them into two groups: patients who had a known history of diabetes, which was based on the hemoglobin A1C criteria of 6.5% or above, or patients who did not have diabetes but had uncontrolled hyperglycemia while in the hospital. Both groups had very similar number of patients, but as expected, when you look at the admission mean glucose, patients with known history of diabetes, their mean glucose was around 240 milligram per deciliter as compared to 175 in the other group. Similarly, the mean hemoglobin A1C was close to 9.1% in these patients with known history of diabetes compared to 5.9% in patients without known history of diabetes. But when you look at the mortality, patients who had uncontrolled hyperglycemia, the mortality was close to 42% as compared to 15% in patients with diabetes, but without having hyperglycemia in the hospital itself. And also the length of stay, mean length of stay was significantly longer in patients with uncontrolled hyperglycemia. The mortality is also depicted on this chart here, again showing patients with uncontrolled hyperglycemia or stress hyperglycemia had significantly higher mortality. So suggesting that more than the history of diabetes itself, maybe it's the hyperglycemia that leads to increased severity of illness. Similarly, another study by Zhu et al., which was another retrospective analysis of 7,300 patients admitted with COVID-19 in China. Here also, when they looked at patients with type 2 diabetes and when they divided these patients between poorly controlled or well controlled, which was based on their inpatient glycemic control rather than their hemoglobin A1C or outpatient glycemic control. And the way they divided these patients, patients who had their blood glucoses below 180 milligram per deciliter all the time throughout the hospitalization were in the well-controlled category, whereas patients who had any blood glucose over 180 milligram per deciliter at any point were in the poorly controlled category. And if you look at the average blood glucoses in the poorly controlled was around 196 milligram per deciliter as compared to average blood glucose of 115 in the well-controlled group. And this clearly shows that patients, regardless of their history of diabetes, if they were poorly controlled, they had significantly higher mortality, close to 11%, whereas only 1% mortality in patients with well-controlled type 2 diabetes. again suggesting an importance of good glycemic control or strict glycemic control during the hospitalization. So moving on to possible mechanisms how this stress hyperglycemia can lead to increased severity of COVID-19. So as mentioned before by Dr. Ismail Beghi, that this ACE2 receptor is possibly the receptor of the virus where the SARS-CoV-2 virus enters the lungs and can cause the illness. So there is a thought that hyperglycemia itself can increase the ACE2 expression, which means that more virus can enter the body, which could potentially lead to severe disease. Also, there is some thought that this hyperglycemia itself can cause glycation of this ACE2 molecule, which can perhaps lead to magnification of the degree of inflammation. And similarly, there is a well-known phenomena that hyperglycemia itself can lead to increased inflammatory markers, which also potentially can lead to severe disease. And hyperglycemia has also been associated with increased mortality and severe illness, regardless of the infection, so which could also play a role. So all these cumulative effects can possibly lead to severe disease in patients with COVID-19 and diabetes who have uncontrolled hyperglycemia. Now we know that ACE2, as was mentioned before by Dr. Ismail Beghi again, that ACE2 is not only present in lungs, but it is present in multiple tissues, including the beta cells of the pancreas. So here we have a specimen, a cross-section from a human pancreas from the previous SARS epidemic, actually. So the A section basically shows the H&E stain of the section of the human pancreas, and on the periphery, the dark pink is basically the exocrine pancreas, and the central portion, all of it, is the islet cells. And when they use the stain to look for ACE2 expression, the B is the control specimen, so there is no ACE2 expression, whereas the C section shows all the brown stain is the expression of ACE2, and clearly shows that there is a lot of ACE2 expression in the beta cells of the pancreas. Some of this on the periphery could be in the acinar cells also, or the exocrine pancreas, but most of it is pretty significantly present in the beta cells of the pancreas. So suggesting that the SARS-CoV-2 virus not only enters the lungs, but it can also enter the beta cells and thereby also cause the destruction of islets or beta cells, thereby even worsening this already stress hyperglycemia in this severely ill patients, thereby increasing the hyperglycemia, which by all of these already explained mechanisms can further lead to increased severity of the disease. So moving on to the use of ACE inhibitors or ARBs. So this is the same graph that was previously shown. So I'm not going to go over it again in very detail, but just to show that when patients are put on ACE inhibitors or ARBs, it basically inhibits this ACE1 enzyme here, thereby reducing the production of angiotensin II. And similarly, ARBs or angiotensin receptor blockers also blocks the effect of angiotensin II, which theoretically could be a beneficial phenomena because it could reduce the inflammation and possibly reduce the severity of the disease. But there is also some thought that ACE inhibitors and ARBs can increase the expression of ACE2, which can potentially lead to more virus coming in, but also increased expression of ACE2 means increased angiotensin 1,7 molecule, which is apparently a beneficial molecule because it reduces inflammation. So theoretically speaking, use of these ACE inhibitors and ARBs could be a beneficial phenomena by increasing the angiotensin 1,7 molecule. So let's look at what evidence do we have in this regard. So this was a retrospective study done at the Cleveland Clinic in Cleveland, Ohio, where they looked at 18,000 patients who were tested for COVID-19. Out of these, there were 10% or 1,700 patients who were positive for COVID-19. And out of these positive patients, 214 or 12% were taking either an ACE inhibitor or an ARB. And if you look at their analysis, what they found is patients who were taking either ACE inhibitor or ARB were more likely to be admitted to the hospital, possibly suggesting severe illness. Similarly, patients who were on ACE inhibitors alone or either ACE inhibitor or ARB were more likely to be admitted to the ICU. So again, possibly suggesting severe illness. But before we come to any conclusion based on this data, there is this another study that was from 1,100 patients from China who were admitted with hypertension and COVID-19. Similar number of patients, around 200, were on ACE inhibitors or ARBs, and this study showed totally opposite results. It showed that patients who were on ACE inhibitors or ARBs had a mortality rate of close to 3.7% as compared to 10% who were not on ACE inhibitors or ARBs. So showing significant protection by these medications. So as mentioned before, and based on this data, and there have been some recent studies also suggesting very similar results of ACE inhibitors and ARBs having not any detrimental effect at least. So far, most of the big organizations such as American College of Cardiology or American Diabetes Association and others have suggested to continue the use of ACE inhibitors and ARBs in patients even before developing COVID-19, and even if they develop COVID-19, the suggestion for now is to continue these medications. All right, so moving on to the last part of my talk here is, as we have mentioned that the type 2 diabetes itself and all of these comorbidities basically lead to increased inflammation, right? So now I'm going to talk about what evidence do we have that this increased inflammation is associated with severe COVID-19. So looking at this first graph on this left side, which was from a study by Zhu et al., where they looked at different inflammatory markers. First one is the IL-6 level. So on the y-axis is the IL-6, and the x-axis is the days from the illness onset. And the red lines are the non-survivors with COVID-19, and blue lines are the survivors with COVID-19. And these are patients regardless of having diabetes or not. These are all patients. And as you can see here that even in the early days of the illness, by day 4, patients who did not survive had a higher level of IL-6. And as the days of illness progressed, the IL-6 levels were pretty significantly higher as compared to patients who survived. And similar results were seen in other inflammatory markers such as serum ferritin levels. Also, there's another study by Zheng et al., which was a meta-analysis. They looked at 6 different inflammatory markers ranging from C-reactive protein, procalcitonin, IL-6, ESR, serum amyloid or serum ferritin, and again showed that patients who had severe illness had significantly higher levels of all of these markers, basically. And IL-6 is probably one of the early ones that goes up. So just looking at this diagram here, or a figure here, is, just showing in a very simplistic manner that patients who are not infected by COVID-19 have normal pulmonary epithelium, for example. They do not have any macrophages or cytokines, at least at the site, and normal T cells hanging around, and they're probably asymptomatic. But patients who develop moderate illness or moderate COVID-19 after being infected by the SARS-CoV-2 virus, there is some damage to the epithelial cell, which leads to recruitment of the pro-inflammatory macrophages, which leads to production of these cytokines such as IL-6 and others. And there is some reduction in the CD4 and CD8 T cells. And these patients usually have mild to moderate symptoms. And the first thing we notice is elevation of IL-6 levels. And lymphocytopenia is pretty commonly seen in these patients. Whereas patients who develop severe COVID-19 usually have recruitment of multiple pro-inflammatory macrophages, and they release large quantities of the cytokines, which is, some people call this a cytokine storm or an hyperimmune response. And these are the patients who have severe illness, like respiratory failure or ARDS, and these patients have severe lymphocytopenia. And again, one of the earlier markers we see here is the IL-6 levels. And there have been some studies ongoing by looking at blocking the effect of IL-6, such as the tocilizumab. And there is some decent results early on, but there's still some large-scale studies needed to know more about this. Moving on to this study by Guo et al., where they compared patients with diabetes and COVID-19 and without diabetes and COVID-19, and they looked at multiple different inflammatory markers ranging from C-reactive protein, ferritin, and others, and they showed that regardless of what inflammatory marker you're looking at, these markers were significantly elevated in patients with diabetes as compared to without diabetes, again suggesting that some association with diabetes and higher inflammatory markers could possibly lead to severe COVID-19. And last slide here from my side is, again, another study by Zhu et al. Looking at different inflammatory markers, and the graphs here shows levels of inflammatory markers on the y-axis and days after admission on the x-axis. The blue lines are the patients with type 2 diabetes, whereas orange lines are patients without type 2 diabetes. And again, showing that patients with type 2 diabetes have higher levels of inflammatory markers, regardless of the timing of the disease, even very early on. And when you look at these patients with type 2 diabetes and COVID-19 more closely, and we divide them into two different categories, poorly controlled versus well-controlled, which is also, again, based on inpatient hyperglycemia rather than outpatient glycemic control. Poorly controlled were are shown by orange line, and the well-controlled are the blue lines, again, showing that patients with poorly controlled diabetes had even higher levels of inflammatory markers as compared to well-controlled type 2 diabetes. So again, suggesting that these inflammatory markers are significantly elevated in patients with diabetes and COVID-19, which could potentially lead to severe illness here. So I will stop here, and I will let Dr. Ismail Begi to talk about some management tools and then concluding remarks. Thank you.
Thank you so much, Dr. Rajpal. So major concerns about the medical management of patients. Then we have issues that we need to discuss from the time the patient has diabetes, but before it's infected. But once they're infected, what to do with new onset of hyperglycemia, what to do with blood pressure management and triglyceride management, and some remarks on dexamethasone. Let me just talk very briefly right now about blood pressure management. As mentioned, we recommend ACE and ARBs be continued in the outpatient. Once they get into the hospital, probably they have to be cut back, and other medications may have to get cut back because they enter the hospital often with hypotension, especially the severe cases, so that has to be adjusted. And we don't necessarily continue treatment of triglycerides in the hospital once they're infected with the infection, with the virus, unless the triglycerides are skyrocket high, which requires its own treatment. And there's been some recent studies showing that 6 milligrams of dexamethasone per day seems to help severe cases be less lethal, and this has to be repeated, the study. So I will only talk about that briefly. Let's see. I'm sorry. Yes, I'm sorry. So, so some issues about patients in general on the outpatient side before, hopefully, they don't get people that are not infected. I think to them, we need to discuss what to do and the importance of having optimal control. And this is borne out by a paper by some large number of world experts in diabetes, written as a consensus statement recently, extremely worthwhile reading. And they recommend that we should try to do that, and we should try to do optimal control. Now, we don't really know if treatment of glycemia down to, let's say, 7 or below prevents patients from getting the disease. We don't know that. As a matter of fact, we're proposing a study right now here to answer that very question, because it would make a huge difference if the lower the blood glucose before infection really prevents the infection to some degree. We should know about that. We should be telling patients not to prematurely terminate their medications. And of course, many places, including us, are trying to use telemedicine as much as possible. Once their patients are admitted in the ICU, then I think that glucose control becomes very important. We should monitor the glucose. Even if they're entering without hyperglycemia, we should monitor at least a day or two, make sure it doesn't get out of control. Because as the stress gets increased, their blood sugar may rise. We would have to use insulin frequently and as much as needed, oftentimes many units. We have patients that are using 20, 30, 40 units of insulin per hour in a drip. So some patients become extremely insulin resistant, perhaps related to cortisol that they're secreting themselves and all the immune inflammatory response. The aim is to keep the blood sugar in a reasonable zone of 72 to 180 milligrams per deciliter. We should try to use CGM if possible, because it will decrease the number of events with the nurses trying to get blood pressure, blood glucose meters, especially if this can be transmitted. And of course, our aim is always to prevent hypoglycemia. So it becomes a tough management in the hospital if they're very hyperglycemic. Now, in terms of medications that we are using, the common ones anyways, the metformin. Metformin, we probably should stop when they enter the hospital. It can accumulate with dehydration, the creatinine may go up, and we commonly stop the metformin. The SCA2 inhibitors as well, we stop them before if they get hospitalized. They can cause dehydration and hypotension, so we would recommend discontinuation, and I think that whole group also recommended such. GLP-1 receptors have some anti-inflammatory effects, and if one can closely monitor this, we're not against using this as long as this patient's not in the ICU. Maybe it could be continued. DPP-4 inhibitors also have anti-inflammatory effects, and they're probably safe to continue. Certainly before anybody gets infected, but once admitted again, we would probably stop this. And our drug of choice is, as we mentioned, is insulin, and it may have to be used at very high doses, and of course requires lots of monitoring. Now, what can be done and what is being done? Well, there's a lot of excitement about monoclonal antibodies. There are studies being printed about use of convalescent serum in cases of severity. There are anti-inflammatory agents that have been proposed and used. Dexamethasone, I mentioned them. Statins and GLP-1 receptor agonists and DPP-4 inhibitors have anti-inflammatory effects, as do TZDs. There's a paper showing colchicine may be effective. And then also immunomodulators, as mentioned, perhaps used early is important here, especially the interferons, maybe that they would block replication of the virus so much. And some of these agents perhaps are more effective early on. I know of some studies going on to try to examine this more closely. And of course, we're all waiting for a vaccine. So in general, so as a matter of conclusion, we would conclude that we believe the reason type 2 diabetes is such a bad comorbidity to have for this disease is multifactorial. There are many, many things. When we say type 2 diabetes, it's more about hyperglycemia and insulin resistance. All these factors are in. Patients chronically have some degree of inflammation, which gets worse when they get infected with the virus, and that hyperinflammation may get out of control to a very extreme hyperimmune response that correlates highly with the severity of the disease. So perhaps treatment in this domain will make a difference in terms of outcomes. And we wish to thank you very much for your attention. I thank Dr. Leili Rahimi and Dr. Aman Rajpal, my co-workers, in presenting this topic to you. Thank you so much for your attention.
Thank you.
Thank you.